Buenas noches, bona nit a tothom, buenas noches. Ho farem amb la traducció en castellà perquè la idea es darle la máxima difusión, ¿no? Para Cataluña y se pondrá en la web y en fin haremos un buen mensaje, ¿no? También recordaros que la pasada conferencia que estuvo el doctor Korb aquí en Barcelona también está grabado. Pronto os llegará el enlace, ¿no? Esto, ¿no? Vale. Bueno, us dono la benvinguda. Ara us paso Xavi Llobet, que introducirá un poquito la gran autoridad mundial que tenemos aquí. Me sale mal porque lo hará él, pero bueno, me lo ha pedido y... El Xavi es el organizador responsable del acto, ha coordinado todo un poco, ¿no? Y realmente es agradecer el trabajo, ¿no? Y dar la bienvenida pues, a todos los amigos de siempre. Es un acto un poco informal.
Bueno, vamos a ver, todo esto nace de siempre de la amistad. Y entonces resulta de que nosotros lo que queremos es transmitir nuestra amistad, la que tenemos con Antonio Enríquez, que para mí ya lo sabes tú, y luego Antonio Enríquez con él. Entonces lo que hemos querido es ofrecer esa amistad a todos vosotros, pero además de la amistad, la ciencia. Porque realmente ya hace 2 años ya hicimos una ponencia como esta, pero esta es mejor. Por lo cual ahora yo, con que vamos mal de tiempo, lo que pienso es que presentarle a él, podríamos estar media hora, 3/4 de hora o 1 hora, y pienso que lo mejor que podemos es ir a ver la ciencia, porque si no nos vamos con el tiempo. ¿De acuerdo? Ahora.
Thank you. It's always a pleasure to be here with all of my Spanish friends and colleagues, many of whom migrated to Boston to the best eye training center in the world, probably at the Scapman's Eye Research Institute and at the Mass Eye and Ear Infirmary. And I was fortunate enough to have them as friends and colleagues, most notably my friend and amigo Antonio Enriquez, to whom I will always be indebted. And as I get older, unfortunately, as I get older, what I have understood is the wonderful relationships that one have with people who are dedicated to the same cause, and that cause is knowledge and have a passion for what we do. So for that, I'm really indebted to Tony. Moving on, because we are starting a little bit late, and I've been told that that you people go till 2 in the morning, but I don't think I'll be able to. The subject for tonight is dry eye and Meibomian gland dysfunction. From the beginning, when Tony and I really first published in 1980 to the present time. And it's really a pleasure that the Collegio has allowed us to join them and present this. So for that, I am also very grateful. Okay, great. In the United States now, we have to tell you how rich we are before we can talk to you. And you have to know that we're not going to sell you snake oil or some other very bad things. So I have invented quite a few things, and there's 3 products on the market in eye drops which I have invented or am the patent holder on, and I do receive some compensation. The rest of everything that I have invented, I do not receive compensation for. So that's really a full disclosure. The summary of the entire lecture is a big change in our thinking. And that thinking is where we always believed that fluid, that aqueous, was the cause of dry eye, was the primary cause of dry eye. And it is an important aspect, but it's not the root cause. And the root cause of most dry eyes, if we leave out all of the immunological, severe ophthalmological diseases, but the usual dry eye we see has its roots in the top. And that's a take-home point, that MGD may well be the leading cause of dry eye throughout the world. And there's now multitudes of, and we now know that there's a multitude of publications which support that fact, and I won't go into them all, but they're there. There's over 30 which clearly show that MGD is probably the leading cause. So if you were a clinician and we were to list all of the various methods of treating dry eye, all of the basic classes, not the number of drugs that you could use, there's almost 100. And for the clinician, how do you sort all this out? I mean, it's virtually impossible. So along comes the salesman from company X, and he says, oh, I have just what we need. This is a wonderful drug. It will really help you. Now, of course, it could hurt the liver, it could hurt this, it could hurt immunology, but it's a wonderful drug. So how do we know? How do we really know? And what we should understand, and it's something we don't want to understand, is that 90% of all trials which are published in peer-reviewed journals cannot be repeated. Let me state that again. 90% of all the literature that we depend upon cannot be repeated. And that was found out, that was discovered by a company, Amgen, A-M-G-E-N, a biotech company, who after losing hundreds of millions of dollars buying various products from various companies, found out that it didn't work. And they had 100 of the world's best scientists on that for 5 years, and that was their conclusion. I think it was only 47 out of 51 papers. They could not be duplicated. Only 4 out of the 51 could be duplicated, which is just staggering. You'd expect 30%, you'd expect 50%, but you never expect over 90% couldn't be repeated. So how do we do this? Well, I have here Pavlo and his dog. So we know about Pavlo, we know about his dog. We know that dogs bark, and we know that if we bring the food in front of them and we don't give it to them, they salivate. But that isn't really what Pavlov did. What he taught us is that the simple and the elementary you can always understand without the complex. But the complex can never be understood without the simple. So here we have this big complex story. For instance, do supplements work? And if I were to ask people to raise their hand, do supplements help dry eye? The majority of you would raise your hand, but they don't. And that was just proven in a study. So what do? Whatever is the new thing we like to use, because the patient comes in and the patient says, what's new, doctor? What's going to help me? And it's like going to a dentist, and the dentist says, you don't have to brush your teeth, you don't have to floss your teeth, everything will be fine. Just chew gum once a day and you will be fine. Well, we now know that you have to take care of your teeth, but we don't take care of our eyes. So if we just look at the old definition, and in a lecture I have maybe 10 or 15 of these definitions, but the current definition by the National Eye Institute in the United States, National Institute of Health, said, dry eye occurs when eyes do not produce tears. There's no tears. They don't produce tears. Or when the tears aren't correct. And the primary message is you have an inadequate tear production, we treat tear production, and the focus is on water. The focus is on aqueous. So all of our research is focused on aqueous. So Restasis in the United States, and Restasis in this country, and Restasis all over the world, increases water. On 15% of people, 15% of the time, on subgroups of people. And there was just a remarkable perspective published on that in the Journal of the American Medical Association, that the only thing that works with Restasis is advertising. And the $600 million a year that they spend on advertising is the reason for that. And that was by a very brilliant lady who spent several years looking at all of the literature, looking at all of the data. And she published that article. And that will not be, it's just been published within the past 2 months. And that article will not be dear to particularly people who make Restasis or people who make drugs. Because when you tell people that you're getting nothing more than the placebo effect from most of these things, it's not pleasant. So here we have all of this complexity going on. And all of this is really new. It's really the past couple of years. And then we had the DO's 2, which was just a wonderful meeting. I was a member of the panels. And they defined dry eye as a very complicated disease of the ocular surface characterized by a loss of homeostasis, meaning the tear film didn't stay stable. It kept changing. And we know that. And and it results in certain problems. So it focuses on 6 sequelae: symptoms, tear stability, osmolarity, inflammation, damage. But now, for the first time, it focused on neurosensory. And that's the big one. Because when we're all done fixing the eye and fixing the Meibomian glands, people don't feel better. Because we've insulted their neurotransmitting system so long that we've made it hyperalgesic and we've sensitized it. And these people need a long-term rehabilitation process. So, how many ophthalmologists or optometrists have a service for the blind with the white cane? No, we don't have that. Why don't we have it? Because it's rehabilitation. So the next step in treating the neurosensory is to get involved with that. And for that, we need help. We need to train people who are adequate technicians to deal with this, just like an ophthalmologist, Richard Hoover, many years ago, when he invented the white cane with a Catholic priest, actually, decided that we had to train individuals to work with the blind. So that we have to do. So if we try to simplify it all, the cause of all this, we said Meibomian gland dysfunction was found to be the leading cause of dryness throughout the world. Now what we have to understand is that it's desiccating stress. And what is desiccating stress, which we'll define as we go along. But if we allow desiccating stress to go on longer and longer and longer, a broad spectrum of sequelae may follow, will be the result. So we have to treat the cause of the desiccating stress and the resulting inflammation. Inflammation does not cause dry eye, except in a very small group of those who have immunological problems, such as early severe rheumatoid arthritis and these other conditions which are very rare. And they're an exception, and there's always an exception to any rule. But the cause of all of this is to treat the desiccating stress. So where did all this start? Well, actually, recognition of MGD. We always knew, when I was trained, and I wasn't trained very well, but when I was trained, there was meibomitis. And meibomitis meant severe infection of a meibomian gland, hordeolum, a chalazion that became infected, or whatever. And the definition of the words was never great. I mean, everybody just referred to them as styes or chalazion, and the terms were not used correctly. But the important point is that it was an infective process, and that is quite rare. But what we discovered is the fact, with contact lenses, that there was no infective process, that you could look at these individuals and they looked perfectly normal. And the best ophthalmologists and the best optometrists in the world, looking at these people, until you press the Meibomian glands, they look normal. So the best of us could never have understood this, because there's a word in English, and I don't know how it translates, but it's non-obvious, meaning not obvious to the person looking at it. That's precisely what it means. And looking at it even further, it would be if a person came in and they looked healthy, as if you went to your general physician and they said, well, how do you feel? I look healthy. I feel great. And they say, you don't have any problems? Well, maybe, I have to urinate a little bit too much at times. Well, would it be hard to believe that that person 3 months later would be dead from prostate cancer? It would be hard. That condition would be non-obvious. So all of these situations where you hear about individuals who in their medical exam look normal and several months later, unfortunately, they have great problems, they're non-obvious conditions with normal testing. So that's where we were when we first published this paper. And what we found is, and this is the take-home, another take-home point, obstruction of the glands at the orifice is the cause of the dysfunction. Because if the gland is obstructed, it can't secrete. So if you have obstruction of the bowel or the urinary system, you have acute pain, you have all of this. That doesn't happen with these glands. It's a slow, insidious process that isn't obvious until it really becomes severe. And then we see it in the severe cases. And when we see it in the severe cases, when it's very severe, we look at it and we don't understand its normal development, its normal etiology, how it develops. And this is a fantastic slide of Dr. Henriquez, and he will explain it to you. But the important point to understand is that it's really, really, really obstruction. Now, the definition of MGD, and it was an excellent definition, happened in 2011. And it was defined as a chronic diffuse abnormality of the Meibomian glands, commonly characterized, and they got this right, by terminal duct obstruction. So that's a definition that really, really is great. And that could result in alterations of the tear film and all of the sequelae that we normally think of. So I asked Dr. Henriquez, and Dr. Henriquez and I spent a little time looking at slides which were made in 1980. And if they were published today, and they should be republished today, they would be the paper of the year because it's so non-obvious, it's so simple, but yet just so important to understand it. And Tony Henriquez is one of the few people in the world who I can say that despite his immense capabilities, he's really a friend to everyone. He respects knowledge, he respects people, and he's ideal. Tony.
Okay, very good. When we hear about glands, immediately come to our mind cells that produce secretions. And typically, an eccrine gland is like the one you have here, like the lacrimal gland. Usually, these cells arrange around acini. And in the middle used to be an empty space where the cells release their secretion. This is normal. These spaces are connected in turn with other channels that transmit or conduct the secretions to bigger channels, and these channels in addition will deliver the secretion to the destination, the upper part of the country. No obvious. It's clear, okay? Do I need this thing? Better. Okay, thank you. Can I have the next one? Meibomian glands are different. Are different because the acini are arranged around a duct, a general duct. And the glands here, the cellular glands here, better seen in this other slide on the right, the cellular glands, these cells produce the fat inside themselves up to a point when they can't hold it anymore and explode. Where do they explode? They explode inside the duct, as you could see here, exactly at this point. So it's the entire cell, the one that delivers the secretion. It's not a secretory gland. Okay, it's an excretory gland, and it's a holocrene gland. Keep that in mind, and also please keep in mind another thing. Observe that the excretory duct is lined by epithelium, epidermal epithelium, exactly like the one of the skin you could see here. The stratum granulosum, like in the skin, all these details are here, inside the duct. So the same that happened to our skin happens inside the ducts. We renew our skin every 10 days. It's new, okay? The ducts too. So, could we have the next one, please? Normal skin, see, this one. Normal skin, okay, with epidermal cell detaching from the surface. These granular cells correspond to the stratum granulosum of the skin. And this is the basal cell layer of the skin, normal, okay? under certain circumstances, this epidermal turnover, this growth of cells that end up being released and renewed continuously, this epidermal turnover is increased, as you could see here. And instead of few scales of epidermal cells, you could have many, as you could have here. This is a case of seborrheic blepharitis, very common condition. And you have here. Imagine all these cells inside the, could you have the next piece? Inside the duct. What could happen is that if you don't blink enough, or under certain circumstances, these cells accumulate inside the duct in the form of plaques. This was expressed by Donald from a patient with Meibomian gland obstruction. And this is what we found. This is the plaque. See? It's epidermal cell, epidermal tissue. Okay? Obstruction. Could you have it? So you could see what happened. On the left is a normal. This is the lower lid. This is the lid margin with the epidermal cells detaching. On the left is the conjunctival side. This is the tarsal plate. Inside you could see a Meibomian gland with the duct in the middle. On the other side, at the same magnification, the conjunctival side, but the duct, in this case of the right, is much bigger than the left one. It's obstructed by something. By what? By sebaceous material coming from the sebaceous glands, plus detached cells from the duct wall. Is clear that passage? Okay, good. We have the next one, please. So this is a drawing just to show the point of the obstruction. Okay, next one, please. But in addition, another finding was that these detached dead cells serve as a fantastic culture medium for bacteria, as you could see here. This is an alive cell. I am lining the limits of the cell, the cytoplasm. This is the nucleus, so it's a cell that is alive. We could know that it's also from the stratum granulosum that was scraped off from the lid margin by Donald, because it has dots in the cytoplasm. So these are no bacteria. Okay? Here, in this other example, another detached alive cell was also from the stratum granulosum. Okay? No bacteria. But the neighbor cells, dead cells, contain bacteria, as you can see here. Those infection. Next one, please. That is the second message I would like to deliver. I hope it's clear that in these cases, as you all know, infection is another component due to the growth of bacteria in the appropriate culture medium, that is the one you could see is delivered from these different cells, dead cells, cellular debris, and all this stuff serves for the growth of bacteria. But doesn't mean that we have to always treat the Meibomian gland obstruction with antibiotics. Just by expressing and delivering the content, we could eliminate all this. This is another possibility. So keep in mind, number one, that we shouldn't immediately think in medicines, antibiotics, steroids, anti-inflammatory drugs, and all this stuff. With hygiene, yes, the expression, and many of these cases, as Don will further explain, could be recovered. Okay? I hope it's clear, the message. Okay? That is the documentation. Thank you, Donald. Yours.
So basically what he presented is, what Tony just presented is the whole concept that we have these plugs, and I'd just like to add a couple little points. It's impossible to understand how small the duct is. It's just impossible for us. And the only people who probably can understand it are the people who end up studying the end of the arterial system where the arteries just become so small you need tremendous magnification to see them, I imagine. It's extremely difficult to picture it. The inside of the duct, you would think, as a physiologist, would be lined with you'd absolutely not want to line it with squamous epithelium, because squamous epithelium is very difficult to keep clean. And yet this duct is lined with squamous epithelium. And the only reason that it's lined with squamous epithelium is it's probably a necessity for it to maintain its structure, because the squamous epithelium, I understand, is much stronger. And what happens inside the gland, as Tony demonstrated, when this epithelium sheds and has a normal life of 10 days supposedly, but with certain people and with older people, it turns over much more quickly, even as quickly as 2 days. It forms filaments, just like filamentary keratitis. So you have these filaments that are sticking out within this microscopic duct, and they act as a spider's web to trap material coming up. And then people don't blink enough in today's society. So this junk gets stuck in that area. And if you, for those of you who have seen filamentary keratitis, you'll know that the filaments, if they go on, collect mucus at the end. The mucus hardens because it's out of its area, and you have a big ball, or you have some other growth at the end of the filament. And then every time you blink, it hurts. Well, inside, if you can just picture that that's really happening inside the duct itself, and forming a spider web and causing this problem. And once you understand that, then, as I explained to the cameraman before we started, those of us who stare have to implement blinking. And the older we get, the more blinking we need. Even as the older we get, the more dental care that we need to stop all of this accumulation of debris that ends up being so harmful. What is the prevalence of MGD? It's extremely hard. There's a lot of studies. They don't mean too much. There's a study which shows in the United States that 86% of all dry in the United States is either due to MGD or has a significant component. But it's high. All you have to know is that it's high. Now, let's talk about how does the eye defend itself, okay? So if you or I were the great maker, and we had control over the design of a better Homo sapiens, what would we do? How would we defend it? How would we defend the cornea? How would we defend our vision from infection, from all of the problems that we would have? We would put a very strong tear film or something in front of the eye that we could see through. So what we want to do is we want to protect the tear film. We want to protect against, I keep coming back to desiccating stress, causing the stress on the corneal neurosensory system, the nociceptors that causes all this problem. So we want to protect these corneal nociceptors, and if we don't, we'll get discomfort, ultimately we'll get pain, ultimately we'll get sensitization. Now, to explain this, there's a test that I'd like all of us to take. We call it the staring test. And I'm going to ask all of you to stare when I say. So I'm going to ask you, don't do it yet, I'm going to ask you to blink once, blink twice, then don't blink once, don't blink twice, don't blink twice, don't blink 3 times. So we're ready. Okay, blink once, blink twice, blink again. Now everyone stare 1, stare 2, stare 3. Raise your hand when you feel something. Stare 4, stare 5, stare 6, stare 7, stare 8, stare 9. Okay, you broke first. Why did you broke at about 2.5 seconds? Why did you have to blink? You felt what?
Not pain, but discomfort.
Discomfort.
Yeah, because I'm tired.
You're tired today, okay? I'm tired today too, but I don't feel discomfort. Okay, anyone else want to articulate, to state what they felt when they broke, when you had to blink?
Discomfort.
Discomfort.
Yeah.
Okay. Any burning? Did you have burning or stinging? Okay. Okay. Burning and stinging can be proven to be stimulation of the corneal nociceptus. And Carlos Belmonte has proven that. So that's when you don't have enough to protect you. Now, if you had scratchiness or grittiness, that's because the surfaces of the eye are rubbing, and that's a different nervous system. So that test is very helpful. So even with patients, a very helpful test is just to say, explain to them, just like I do, blink once, blink twice, and stare. The whole test is over in 30 seconds, including the explanation. And then you say, that shouldn't happen. You should be able to go 10 seconds. You should be able to go 15 seconds. So that's a very quick test that we have developed over the past several years since I've been here last. Now, if we talk about what is the mechanisms, and I don't like these complicated charts, because complicated charts aren't simple. And we should try to make everything simple and build a simple to answer the complex. But if we just think of, there's really just two ways. You have this desiccating stress, which we just had. Now, if we put you on a computer, or we put you on a computer, you would not blink every 2 seconds. Here, when I said stare, your conscious system is working, so you have to blink, because the alarm system goes off, and you blink, the alarm goes off. But when you're staring at something for survival, the alarm system doesn't go off, because that's for our survival. So we were trained for a short length of time to be able to stare. But unfortunately, we then suppress the neural system, which causes us to blink, which in turn sends us down this particular route. And it sends us down the route of the lipid secretions decrease all day, the evaporation rate increases 4 to 16 times. All that work was done at Scapins in actually the 60s and 70s. Decrease in tear film thickness, unstable tear film, the whole thing. Then it comes down to inflammation, ocular surface damage, staining, the entire situation. And ultimately what it leads to is a loss of your Meibomian glands, and we'll get into that later. So now we're dealing with Meibomian gland atrophy. So all of a sudden, the very simple has become catastrophic, because we are losing our glands. And that's what's happening to our young people today. We are losing our Meibomian glands. The other route is Meibomian gland obstruction, which causes exactly the same problem. Because when you have Meibomian gland obstruction, you never have enough lipid to protect the ocular surfaces, so the alarm system is going off all the time. So if there was an alarm system on this building, the alarm system would be designed to work for 5 minutes, for 10 minutes, for 15 minutes, make a lot of noise, get the police here, get people here, and protect the facility. But with the eye, what happens? When we sit at a computer for 10, 12 hours, or in surgery, when you're staring through a microscope, as the Japanese proved, all day long, because all you do is surgery all day long, one right after the other, and you're looking through the microscope all day long. You're staring all the time. You're staring because you're anticipating problems. You're anticipating the next step. So you set the alarm system off, but the brain suppresses the alarm system. But the damage is being done because you still have the desiccating stress. So what's happening is the alarm system results are just going on all day long, and not for just a minute or two as we have in desiccating stress. And that's what leads to this entire problem. Okay, so let's make it simple again. Okay, so I've explained a lot of things which are all very simple, but as they come together, they make the complex simple, because each one of the individual parts, when they're added up, are as simple as 1 + 1 = 2 and 2 + 2 = 4. It really is that simple. So how do we diagnose that we have this situation? Well, I think of something that I worked on with Caroline Blackie in Boston for several years, and we can do it by function and structure. That's all there is to it, function and structure. We can tell when people are in trouble by function and structure. So when we look at the Meibomian gland structure, it should be normal. It should be just like the pictures in the book that Eugene Wolfe first put in The Anatomy of the Eye in Orbit going back to the 1940s. And they're just beautiful pictures. And that's how this meibography, where each gland is very clear, where there's not a lot of dilation at the end. And how do we do that? We do that with the meibographer. Although we can also do it by transillumination. You can teach yourself with a transilluminator just to put the transilluminator there, invert the lid with it, look under the microscope carefully, and after you've done 50 or 100 patients, you'll be quite good at it. But you just have to be persistent in learning the technique. No, and it's very simple. It really is. I mean, I was out at the school today in Tarraso, and when you see people trying to learn retinoscopy, I remember when I was a student, I had to learn retinoscopy. Oh, my God, it was so difficult. You look at the shadow, and the shadow is twisting. And then along came a man named Copeland, and he named the Copeland streak retinoscope. And he just said, this is all very simple. Let me show you what you do. You just bring up the light, and you shine it in the eye, and you watch the motion, and here's how you do it. And all of a sudden, he made it simple. And all of a sudden, I could do retinoscopy. And then he explained to you at the next course how to do it quickly. How not to use lenses, but how to estimate coming in and out the distance and quickly judge the distance, and you could tell how much myopia or how much cylinder an individual had. And that was so exciting in those days to be able to do it. But the way it was normally taught, it just took forever. So all you have to do is just practice this, and that was it. By the way, Copeland thought that he would pick his wife by her genes. He was sure that he could do it because he didn't want any myopia in his family. So he carried this little small retinoscope in his pocket like a thief. And when he met the in-laws, and he knew they were good, okay, he got the children all badly myopic, So he was trying to figure out why. So he went back, looked at the parents, not myopic, no cylinders, no problem. He didn't do the grandparents. That was the problem. So there we go. So with meibography, that's how we look at the structure, and this is just so important. And then the second way is with the MGE. Now, how do we test the function of the Meibomian glands? We'll talk about that in just a second, but that's how we used it. Now, we can also look, and whenever you look at a lid like that, and the lid is serrated, and the lid goes up and down, you know that you have MGD. You know you have MGD. So you don't have to be fancy. All of this other work is good. I mean, I like it. I like to have the data. I really love the data. I'm a data person. But if you have 5 seconds in the clinic, and you want to make the diagnosis, and you look at the lid margins, and they're like that, you have advanced MGD. Because the MGD has existed long enough so that you have atrophy. And when you have atrophy of the Meibomian glands, what happens? They lose their form. So the lid margin becomes serrated. The meniscus looks like the Mediterranean Sea in a storm, not when it's smooth. It looks like the meniscus goes up, the meniscus goes down. It's not good. We have a smiling gentleman here. The two of you, you just came in.
No, I've been there watching you.
You've been here watching me. Oh, you got a liposcan.
Yeah.
Oh my goodness, you got a real liposcan?
Really?
Does that work well?
Well, you know better.
I should. I invented it, but sometimes I forget what I did. You know, my memory's poor. Okay, but we will get on to that. So what have we answered with? What I should tell you is, because I don't have a slide on it, this little instrument to examine function, and I'll pass out a couple. Good catching. Good catching. 100%. When you press in that, it's designed to provide the amount of pressure on the lid margin that a normal blink does. So if I say to somebody, shut your eyes down, and you're holding that instrument right like that against the lower lid, and you're holding the just like that against the lower lid, and then you press in, because there's a system of springs within that instrument, you can only press with 1.25 grams per square millimeter, which is the same amount of force the muscle of Rylan gets when you shut down. So you know that if when you look through the slit lamp with that instrument, if you don't get any secretion, what do you know? You know the gland isn't functioning. Okay? So if you also have Meibomian gland structure loss and the gland isn't functioning, you've got big troubles. But you can have a perfect lid like that, and still not have any material, any sebum come out, because as Dr. Henriquez has shown us, we have that plug. It was so exciting when we expressed those original people and had this plug come out, and then you went back to Scapins and you looked at it. It was just incredible, an incredible experience to understand that these glands can be plugged. We didn't know anything about it. All we knew was they had a plug in them. You know, just like a young person knows that when you that if there isn't a plug in the wine will evaporate. But they don't know the bio characteristics of the plug itself. So at any rate, just summarizing, this is invaluable, and it's used like that against the lower lid, like I exhibited. And the lower lid is serrated, and that serration immediately tells you that you have Meibomian gland dysfunction. Now, what have we learned? Well, with this instrument that I'm passing around the room, with this instrument that I'm passing around the room, what we know is that the nasal glands contribute more sebum to the eye than all the other glands together. What we know is that the temple glands almost never secrete. We don't understand that yet. We think it's a reserve system. We think it has to do with temperature. There's a lot of reasons. But basically, it's only on a very, very, very well-trained athlete that these temple glands secrete. So you don't have to worry about that. But what you do have to worry about is the nasal and the central. The nasal probably contributes 65% or 60%, the central 30 to 35%, and the temple less than 5% of the glands are functional. And that resulted in a series of studies where if you have 0 to 4 glands in the lower lid, if that's all you have that are working, you're in the red. You're undoubtedly going to be, quotes, dry, because there's not enough oil to do what? To protect the tear layer. So the tear layer evaporates. So if you're left a drop on your kitchen counter, if you're left a drop of olive oil, and you're left a drop of water, and you came back the next morning, the water would be gone and the lipid would still be there, because the lipid doesn't allow evaporation, to make it simple. So, and if you have 8 glands or more, you're probably not going to be dry. So, contact lens success, which is very, very important. Well, if you have less than 4 glands working in the lower lid, contact lenses probably will not be ultimately successful, because what they will do is they will cause burning and stinging and other problems, and they'll cause desiccating stress, and they'll start the whole cascade that we just attempted to explain. But if you have 10 or more glands, particularly 11 in that study, people are asymptomatic. So if you have a lot of glands working, contact lenses work great. If you don't have many glands open, they don't work great. And again, this device, which is called actually the Korb Meibomian Gland Evaluator, that particular device is just invaluable for all this. Now, let's talk about the dentist. I had my first tooth pulled several months ago. I was scared. I was really worried, you know. And they went in, and the first attempt wasn't very good. He said, "Don't worry about a thing. This will just come out." So I just have to twist it the other way. He was very good. I very carefully picked the person. He was very good. And I actually sent my daughter as a trial first to see how good he was. And he was very good. So knowing that he did my daughter well, and she's very hard and very... So I went to him. He also was a patient, and he's well known. So I went to him, and he got the tooth out. It was just miraculous. He actually knew what he was doing. I was so happy. I thought he was going to do something terrible with knives and everything. He just twisted it, and out it came. So, but he took an x-ray first. And that x-ray helped him understand what he had to do because he could see the roots. So if he didn't do that and he didn't have a method of imaging, he would not have known what to do. So that's much the same as here with imaging glands. So this little instrument over here is something which I guess I have the patent on, or I'm one of the two who have the patent on it. And what that will do is that will give you nice clean pictures. And we were hoping that you'd arrive nice and early, so as these people came in, we'd give them a gift of a personal liposcan on their eyes. But now, if there's time, it would be good. But if there isn't time, they'll just have to look at the pictures. They won't, maybe it's better. They won't even know how bad they are, so they'll feel better. So this is the normal, and this is when we have some dropout. And we can have individual glands that drop out, or we can have glands that are truncated. Or here, we've lost almost all of the glands. So if you have a patient who presents like that on both eyes, unless they have developed some corollary system that we don't yet understand, like people who have coronary blockage, they develop accessory vessels. I think they call it a corollary system or whatever. When they have that problem, they develop an adaptation to overcome it so they can exist. So maybe there is something, but we don't see it. But these are the people who are extremely difficult to cope with because we can't get their glands working. You can treat them forever, but you don't have any acini. And Dr. Henriquez explained that each one of those little dots is an acinus. And what are there, 20 or 30 in each gland, Tony? About 20 or 30. So instead of having a 20-30, you might have 1 or 2 on these remnants. And they don't work very well because the gland has atrophied. And there's a whole reason for atrophy, which we hopefully will be able to get into. So what this also results in is chronic, very severe ductal dilation, and the dilation goes right up. So the space between the acini just opens and opens and opens and opens because all this material has been secreted before the gland shuts down. And this is a long discussion, and we think we now, Dr. Henriquez was kind enough to work with me recently right here in Barcelona, and we think we're beginning to understand it. But there was a paper came out of Dr. Jester's lab by Sulhalem, and what they did with mice is they took mice and they didn't treat them well. They put one group of mice in a happy home where there was high humidity, there was good food. The mice were very happy. And they sacrificed them, and their Meibomian glands were perfect. Then they took another group of mice, and they put them in the same cages, but they put them in a different room. And in that room, the humidity was low. And in that room, there were fans. And they subjected the glands to desiccating stress. And in a period of time of a certain number of months, short, which corresponds to about 4 or 5 years of a human lifespan, the mice lost all of their glands. Gone. By desiccating stress. And that's what we're doing in our society by the contemporary electronic methods of forcing people to stare and having desiccating stress. There's just no question about it. The evidence is clear. And there's paper after paper now which comes out, and we'll just quote a couple of them, which just show that the students, the new millennials, have lost a significant percentage of their glands. So that's where we are there. And that actually is that instrument, the liposcan, and these are slides from it. What's unique about that instrument is it takes 2 forms of imaging. It takes frontal illumination with infrared, and it reflects back, and it captures that image. And then the next step is to transilluminate them. And then the computer does the job of blending the two and telling us precisely what glands are lost. So if you only do one, you can miss about 30% of what you should be seeing. this is a study that we presented at ARVO this year, just several weeks ago. And what it shows is that here's the number of glands that are working, starting at 0, going up to 12, 13. And you'll never get 20, except in a wonderfully conditioned human being. But most of us, if we have 10 or 12 or 15, that's fantastic. And what it shows is that as the number of glands goes down below 5, then you lose your structure. So you can tell by the number of glands that are functioning the probability of how many glands are beginning to atrophy. And that shows that there's a lot of scatter, as we would normally expect. So the recommendations from this study were that if you have 10-15% gland loss, that's not much. I wouldn't worry about it. When you start getting up to 30, 35, you're starting to get problems, and these people have to be treated. By the time you have 50% or more glands that have problems, you're too late. These people have to be treated reactively, and they may never fully recover. But you have to stop it from getting worse. And then, as it gets higher and higher, treatment is, you just try to save what you have. But once it gets up over 90%, you're never really going to be successful of rehabilitating them. And what we have to remember, again, is the pathogenesis of this, that, again, obstruction is the primary cause of MGD. It was in 1980. It is in 2018, and it will be so 100 years from now, because nothing's going to change. We won't evolve to solve this particular problem. Excuse me 1 second. I need to get them vocal cords going. So, and there's just tons of references about this. Steve Flufelder has 15 papers on desiccating stress and what it does in little minute areas. So he had a fellow for 2 years who studied one little action and what desiccating stress does on it. And desiccating stress just kills this enzyme, it kills that enzyme. It's just extremely complicated. But the story is not to study. That's wonderful information to have if we need it, and ultimately perhaps a drug will be developed against one of these little things or multiple. But the important point about it is what? It just shows that desiccating stress is absolutely catastrophic to the cornea, to the neurosensory system, and to dry eye. And this was the landmark paper that I just talked about. The mice are in a low humidity environment, and they have early aging, Meibomian gland atrophy, and dropout. And you know, when you think about it, we talk about dry eye, but dry eye is really the wrong diagnosis for millions. If there's 15 million people a year diagnosed with dry eye in the Western world or more, then probably 80% of them, dry eye is not the diagnosis. Dry eye is a sequelae. It's the result of this process. And I don't want to change the name of her because we understand it. But we have to change our thinking as to what it really is. It's not aqueous. It just is not aqueous. It is aqueous, but treating the aqueous system without restoring the whole system and preventing it from evaporation just won't work. So if we want to make it simple for the patient says, well, what can I do? After 5 years, a year ago, I figured out how to explain it to people. Here's how you explain it to people. You say, if you didn't have a dryer to dry your clothes, and you had to hang them on a line, tell me the day that you would choose to hang them on the line. What do you mean, they'll say? I'll say, well, would you hang out your clothes on a day when it was raining hard? Well, of course not. Well, why not? Because it's too wet. The laundry will just get wet. It won't dry. I said, well, tell me when it will dry. Oh, now I understand. It dries when there's wind. Yes, it dries when it's wind. And it dries when it's hot. Yes, it dries when it's hot. And when else does it dry? It dries if there's low humidity. So if you have low humidity, a hot temperature, and wind, it dries. Anything that dries your clothes on the line will do what? It will dry your eyes. That's all there is to it. That's all there is to it. It's that simple. So, why is that important? Because the patient would say, well, I got a fan in the ceiling that at night it bothers me. Well, would that dry your clothes? Well, sure it would dry my clothes. Not good. Get rid of it. You know, my boyfriend, he's a wonderful man. And he has this big new Harley Davidson motorcycle. And he takes me out. And he says, you really don't have to wear goggles. You know, just wear a little bit of eyeglasses on you, and it will be good. You'll look better. Is that good for me? Would it dry your clothes on the motorcycle? Yeah. So you can go through all of these things, and it answers almost every question. And now what we've done is we've made it simple for the patient to understand how they have to join the barrel. And the dentist says, here's the toothpaste, here's the toothbrush, here's the floss, here's the plastic bag, go do it. Okay? All we have to do in our field now is tell them about the laundry story. And there's many causes: wind, low humidity, computer use, contact lenses, lid seal, partial and frequent blinking, blepharoplasty, as all ophthalmologists know, is a disaster with many people, and all of these other assorted lid conditions. Okay, so desiccating stress impacts what? Again, repeating. Johnson & Johnson doesn't do this, but one of your competitors tells their detail men and their salesmen that you have to repeat it 7 times to the doctor before they understand it. Well, I think they're really exaggerating. I think it's only 4 or 5 if we listen, but sometimes we don't listen. So what happens with all of this? What happens is that desiccating stress does this, but it does something else too.